A very good morning to all of you, respected faculty members and seniors. Today, I'm Dr. Veeram Lunia, third semester JR in the Department of Emergency Medicine, and my moderator for this topic, neck injury, is Dr. Jamshed sir. So first, I'll start with the anatomy of the neck. Basically, I'll deal with the triangles of the neck, this anterior and the posterior triangle. The anterior triangle, it is bounded anteriorly by midline of the neck and in base by the clavicle and laterally by sternocleidomastoid. And the posterior triangle is formed by the, so and the anterior triangle is anteriorly by the midline of the neck, the sternocleidomastoid, and the clavicle in the base. The posterior triangle is by posteriorly by trapezius, inferiorly by middle one third of clavicle, and anteriorly by sternocleidomastoid. Basically, our neck is divided into three zones: zone 1, 2, and 3. The zone 1, it starts from the clavicle to the cricothyroid cartilage. The second zone 2 is from cricothyroid cartilage to the angle of the mandible, and the third is from angle of mandible to the base of skull. So content of the zones. Zone 1, it contains great vessels, subclavian vessels, and the arch of aorta, esophagus, trachea, lung apices, and cervical spine, spinal cord, and cervical nerve roots. Zone 2, from cricoid cartilage to angle of mandible, is carotid, vertebral artery, jugular veins, pharynx, larynx, trachea, esophagus, and cervical spine and cords. Zone 3 is from mandible to base of skull. It contains the salivary and parotid glands, esophagus, and the carotid arteries with the same major nerves. The facial planes. It is divided into superficial and the deep facial planes by the muscle platysma. Uh, if anything above the platysma is superficial and if the deep is deep, it is divided into two. It is the platysma is enclosed by fascia, anteriorly by superficial fascia and posteriorly by deep fascia. The most important thing in the neck injury is the hard and soft signs. The hard signs is the vascular injuries. First, like shock, irresponsible to initial fluid therapy, active arterial bleeding, pulse deficit, thrills, broods, and any pulsatile or expanding hematoma. And the counterpart of the soft sign is the hypotension in the field, there is history of arterial bleeding, non-pulsatile or non-expanding hematoma, and proximity of wounds. The second is the laryngotracheal injuries. The hard signs are striders, hemopsis, dyspnea, air over the air bubbling over the wounds, and airway obstructions. The soft signs are the hoarseness of voice, neck tenderness, subcutaneous emphysema, cervical ecchymosis, tracheal deviations, and restricted movement called mobility. The pharyngoesophageal injury doesn't have that hard sign, it is contained mostly soft signs. This is odynophagia, subcutaneous emphysema, dysphagia, hematemesis, or severe neck tenderness, prevertebral layer, etc. First, I'll start with the airway and subsequently breathing, circulation, and disability. Airway. The patient with following signs and symptoms may require immediate airway control. First, shock, not responding to initial fluid therapy. Second, airway obstruction. Third, impending airway collapse. And fourth, profound undermental state, means obtended mental state. For these patients, we mostly try for rapid sequence intubation, like cricoid pressure and positive pressure and ventilation may worsen the airway injuries. And most, if possible, perform awake intubation because and something when this it's contraindicated, like and difficult to ventilate the patient, pre-oxygenate the patient with facial airs, unstable mid-facial fractures, airway obstructions, and vomitus or blood in the field. Mostly we don't, here we start with the sedatives, do not administer much muscle relaxants. And most preferably if you have video laryngoscope, so start proceeding with this. This is the Laryngeal mask airway. This is a temporary method, bridging device. Before, if we are not, if the time is taken more for the intubation, so we'll start with the, let's secure the airway with this. What are the clinical factors which are indicating aggressive airway management? First, I have talked it earlier also. Stridor, acute respiratory distress, expanding hematoma, airway obstruction, profound shock, and obtended sensorium. And if all fails, then what we have left with the surgical cricothyroidotomy. There is absolutely no contraindication for cricothyroidotomy. Mostly it's preferred more than age of 12 years. And the relative contraindications are tracheal transection, fractured larynx, and laryngotracheal disruption. The second part of the breathing, most commonly is what we see here is the neck trauma is the hemothorax and the pneumothorax. Can anybody tell the triad of tension pneumothorax? Neeraj?
Hypotension, bradycardia, action.
Raise JP. Absent heart sound, breath sound. Nice. So, uh, so as we know, the tension pneumothorax, the triad for tension pneumothorax is raised JVP, decreased breath sound, and hypotension. So as we all know, the management for the tension pneumothorax is immediate is needle thoracotomy, and followed by the permanent confirmatory or the definite treatment is ICD, which is done in the fifth intercostal space, just anterior to the mid-axillary line or anterior axillary line. The third part is the circulation part. Most commonly, the neck trauma, the blunt trauma. There is expanding hematoma is the most concern for the ED department. First, exsanguination is the proximate cause of death in most of the patients. The massive bleed from trauma kills more rapidly than airway. Control bleeding by direct pressure, and don't climb the vessel in ED blindly because this may cause cerebral anorexia and nerve injury. And also, we have tried some method of Foley's is also used in this for creating tamponade effect in the bleeding vessels. As we all see, this is a Foley's catheter, which is tried in the zone 2 of the neck. It has also been sutured and closed to make the tamponade effect to stop the bleeding. So management, like first start with the hemostatic dressing, which is effective in mostly 95% of the cases. If it fails, then immediately shift the patient to the OT. If subclavian vessels are involved, then zone 1 can also be taken up toward the OT. Fourth is the disability. The cervical spine injury. It is uncommon in awake and neurologically intact patient with an isolated penetrating neck trauma. The vertebral fracture and spinal cord injury is rare in isolated neck stab. Spinal cord damage is more common in gunshot injuries. Penetrating injury and vascular thrills and Brug's hematoma are more common. So going through the investigations, we have the five sets of investigations like MDCTAs, multi-detector CT angiography, digital subtraction angiography, MRI, chest X-rays, and point of care ultrasound. And initially, what we start with the diagnosis and treatment. They ask the patient for do the simple maneuver like ask to cough, swallow, speak, and structural physical examination. Like if the patient is coughing and having blood in sputum, so hemoptysis, there may be bleeding inside. Ask the patient to swallow if there is any dysphagia is there or not. Ask the patient to speak, like laryngeal fracture is there or any hoarseness of voice are there or not. Like in most of the like 95% of the patient can be structural means diagnosis can be confirmed by a structural physical examination itself. 9 out of 10 patients with the heart sign are taken up for OT, means surgical repair is done. Now, penetrating neck injuries. It is mostly 1% of the total traumatic injuries. Most commonly, like gunshot injuries, stab wounds are the more predominant. The gunshot injuries more causes vascular injuries than aerodigestive injuries. Vascular injuries are the leading cause of death in penetrating neck injury. Like we have a question we have learned in our PG preparation time, like all zone 2 injuries should be go for OT repair, not 1 and 3. But it's not like that. Like I'll be dealing it subsequently. Like penetrating vascular injury, it is mostly present in 40% of the neck, penetrating neck trauma. The bleed, slight of the bleed is arterial or either can be venous. Arterial is most of the time is 45% due to carotid arteries. And the venous is 20%. This does not require any surgical repair. It is mostly asymptomatic and patient don't require any repair. The arterial, we have to just control the bleeding due to examination and neurological complications. Like for penetrating neck injuries, diagnosis, first line is MDCT angiography, and highly sensitive, which is highly sensitive and specific. The other investigation which can also be done is color flow Doppler and MRI angiography, because the disadvantage for MRI angiography is it takes the time more than CT. So this is the algorithm for penetrating neck injury. First, if the patient is stable, check injury is violating platysma or no. If no, just observation. If the platysma has been disrupted, just check for the heart sign. If heart sign are there or not. If heart sign is there, take the patient to the emergent operation OR room. If heart sign is absent, check for soft sign. If soft signs are present and absent. If soft signs are absent, just take for the patient CT angiography on selective basis. Then if the soft sign is present, take the patient for CT angiography. Like if there is any suspicion for pharyngoesophageal injury, go for esophagogram, esophagoscopy, and combine esophagogram and esophagoscopy, which has 100% sensitivity to detect any rupture or leak from the site. If this is negative, just observe the patient and discharge as per requirement. If this is positive, then start with IV antibiotics for 10 days and total parenteral nutrition. And if the patient is not is not improving, then take the patient for elective repair. If soft sign for the laryngotracheal injury, pen endoscopy is done. If pen endoscopy is negative, just observe the patient and discharge and follow up in regularly. If pen endoscopy is positive, if the size of the defect is more than 2 centimeters, then take the patient for surgical repair. Otherwise, just antibiotics and conservative management. If soft signs are present, CT angiography, which shows the suspicion for vascular injuries, go for CT angiography, color Doppler, and angiogram or MRI angiography. If it's negative, then same thing, observation, and if positive, take the patient for emergent surgical repair. Blunt neck injury. Mostly it comprises 5% of traumatic neck injuries. Other causes can be assault, pedestrian struck by vehicle, and hanging. Frequent associated injuries are also there. But most in the blunt neck trauma, our concern mostly is the airway occlusion more than hemorrhage because here the airway is compromised. Like blunt carotid vertebral artery dissection. Mortality in symptomatic patient is 60%. Is the most common mechanism is hyperextension and rotation, followed by hyperextension during rapid deceleration. And for this, the gold standard diagnosis is 4 vessel angiography, and which has sensitivity of around 80% and specificity of 97%. Like for the treatment of the blunt carotid vertebral injury, this is based on the grading of the injury. The grades are of 1 to 5. The grade 1 is luminal irregularity with less than 25% of narrowing of lumen. The grade 2 is same, but narrowing is more than 25%. The third is there is pseudoaneurysm, and fourth is occlusion, and the grade 5 is transaction-free extravasation. For grade 1, 2, mostly we can start with antithrombotic agents, and from grade 3 onwards, it depending on the requirements of the defects, whether the patient is to be taken for surgical repair or management conservatively managed. Yes, sir. Upper airway and esophageal injury, laryngotrachea injuries. This occurs most commonly in penetrating neck trauma. Like incidence is 2 to 5, 15%, 2 to 5%, and mortality is as high as 2 to 15%. Mostly soft signs are seen 18%, and out of that 18%, only 15% are diagnosed. Blunt tank injury, which also have incidence of less than 0.5%, may have quiescent phase, which progressively increasing airway edema, which lead to airway compromise. For the treatment of the laryngeal injuries, it also based on the grade. Grade 1 is minor endolaryngeal hematoma without detectable fractures. Grade 2 is edema hematoma, minor mucosal disruption without exposed cartilage, non-displaced fracture. Grade 3 is massive edema, mucosal disruption, exposed cartilage, vocal fold immobility, and displaced fracture. Grade 4 is grade 3 with 2 or more fractures lying or massive trauma to laryngeal mucosa. Grade 5 is complete laryngotracheal separation. Coming on to pharyngoesophageal injury, like it may occur at up to 9% of the penetrating neck injury. It is rare in blunt trauma, but may happen. Clinical feature is more subtle, leading to delay in diagnosis. There is no hard sign, so mostly is oh, this all the signs has been over it's left. For the diagnosis of the pharyngoesophageal injury, the diagnosis is endoscopy. The treatment mostly is treated by conservative management, like IV antibiotics. Small perforation is also managed conservatively. If the defect is more than 2 centimeter and esophageal perforation, they require surgical repair. Now, another mode of blunt neck injury is strangulation. Blunt neck injury mechanism is mostly due to compression of both the arteries and both the carotid arteries. This leads to cerebral anoxia and ischemia, which leads to obstruction to venous return. Like if both the jugulars are simultaneously compressed, there is some cerebral congestion, edema, and unconsciousness. This also leads to loss of muscle tone, which further increases the arterial compression and airway, leading to subsequent anoxia. Like the signs of strangulation can be petechia, neck contusion, and symptoms are most commonly neck pain, voice change, swelling difficulty, and breathing problems. Recovery from severe neurological symptoms is unpredictable. Most common cause of death in laryngeal or pulmonary is laryngeal or pulmonary edema or cerebral anoxia. Diagnosis can be made by CT, MRI, and chest X-ray. Signs of injury are same. Intramuscular hemorrhage is there. Swelling of platysma can be seen. Subcutaneous bleeding and laryngobronchoscopy if dysphonia, dysphagia, dysphonia, aphonia, and rhinophagia is present. Uh, Compression of the KPP. KPP also there, the vibration. The right side JDP, HPC, back, right side heart rate. for treatment of the patient with the pulmonary edema is positive pressure ventilation, and the patient with cerebral edema is anti-edema measures with scissor prophylactic. And also in the pediatric age group, the most common cause for blunt neck injury is abuse, trauma, handlebar injury, and high risk of complication due to high risk of complication can also be there due to radiation, like CTVD, CTs, then radiation is more the children are more exposed for the radiation, and mostly these children are most likely to be present in the airway distress. Uh, Last slide of my presentation. If the patient comes with massively bleed, so just start with the activate massive blood transfusion protocol and start next it's been advised in phase 2 protocol, phase 2 trial. It should be administered less than within 1 hour of or within 3 hours for maximum output. That's it.
This slide only just to sort of summarize that it's not something commonly we see in the right. It's not so common even in trauma center or the rest of the hospital. Just trying to take home message. You see your first presentation of snake bite and second presentation neck injuries. There's a lot of improvement now. The slides are much better. The presentation is much better now. This is the effect of attending this seminar or what? Both. So any question from the panel? Yeah, no. Thanks, question. Not very question, but it's. Anybody else? It's kite staying injuries. Now, we have a series of published from the department.
सर ने बोला था
उसका फोटो था, बस एक बार जाके देख सकते हो कितने अच्छे फोटो हैं।
सर ने दिखाया भी था डॉक्टर गौरव
का पेपर है। So let me ask Rahul, what did you learn of this presentation? कोई भी एक पॉइंट बता दो। Good. Karthik. So you said that you go deep to the blood is not. Okay, what else? What are the other things you learned in this presentation? Talk us through the anatomy of the neck. You described the triangles. You can take the mic. Mic.
Actually, the posterior triangle.
Okay. Yeah.
And the consist of
Yeah. Keep the mic on with you. Yeah. Base of it. Okay. What are the structures present in the anterior triangle and the posterior triangle? Mm-hmm. Okay, Golak. What are the zones of the neck and why are they important? We discussed. So what is the clinical importance of these three zones? In which zone? बताओ जरा, what is the clinical importance of these zones जो आप बता रहे हैं?
Sir, mostly like zone 2 carries more, all the great vessels like carotids. The bleed from the carotids are more dangerous as it can be profusely bleed and the patient can die with the hypotension and hemorrhagic shock. And earlier it was thought to be like zone 2 needs to be emergent surgical repair is to be done. But nowadays what we are following is like any zone can be taken up for the surgical repair unless irrespective of the zone. Like whichever the zone, the more severe is the severity of the bleed of the bleeding vessels or any heart signs are there. This patient can be taken to immediately to the OR irrespective of the zone.
So it depends on the hemodynamic stability and depends on the
Clinical stability of the patient.
अब आ जाते हैं heart signs. So Arvind, what are the heart signs in the neck injury?
So we have in neck injury we are classified as vascular injury, airway injury, and valvular injury. So we have heart signs for vascular as well as airway injury. So in this thing that is vascular, it will be that is shock that is unresponsible patient. Then you can have a pulsatile hematomas, spastic hematomas, active arterial bleeding from the side. Then pulse deficit present through this thing is there. And then when you come to hard signs of airway injury, we can have active hemoptysis, stridor, expanded subcutaneous emphysema, active that is bubbling from the side of the wound. All these will be signs of hard signs of airway injury. There are no hard signs of airway injury.
So we'll pick up Vaishnavi. Soft signs of the neck injury.
Soft signs of neck injury are divided into vascular, laryngoradial, and pharyngoesophageal. So in the vascular, we have if there is hypotension in the vein, if there is a non-expanding hematoma, and if there is proximity wound, and also in laryngotracheal injury, it is either if there is subcutaneous emphysema, which is non-expanding, and there is laryngeal edema, there is cervical ecchymosis or edema, and there is I think hoarseness and neck tenderness. Hoarseness, neck tenderness, and tracheal deviation or cartilaginous step-off. Then in pharyngoesophageal injuries, we have, and also in soft sign, there is this thing I think, yeah, soft signs are of laryngotracheal that. In pharyngoesophageal injuries, the soft signs are the patient has complaints of dysphagia or odynophagia. Then the patient complains of if the blood is there in the mouth or if there is hematemesis, and there could be severe neck tenderness in this one also, and subcutaneous emphysema in this one also. And there is transmidline trajectory or prevertebral air.
What is the clinical relevance of hard signs and soft signs? Why do we have to look for them?
So as Kiran told that if hard signs are present, 9 of the 10 patients presenting with hard signs go to the OR. So it is important for initial prognostication and further management of the patient. And also several injuries like pharyngoesophageal do not have a hard sign and will be usually delayed diagnosed because of the soft signs. So we should be more vigilant for the soft signs and ruling out pharyngoesophageal.
I think the diagnostic algorithm which you had shown, I think you can put that slide. That is, I think you can just repeat that because that is very important. How do you approach this? Like, it should have been is this from Kenali?
Yes, sir. in a penetrating neck trauma, if the patient is stable and the platysma has not been violated, then patient has to be under observation. If the patient platysma has been disrupted, the patient should be looking for heart signs. If heart sign is there, they immediately take patient for the emergent surgical repair. Then, if heart signs are absent, then check for the soft signs. Then check for the soft signs. If soft signs are absent, again, the patient, if hard signs are absent but soft signs are present, then the patient can be taken for CT angiography electively. If soft sign is present, means not, ED. It's not immediately. This patient can be taken time of resuscitation and then shifted for the diagnosis and the if soft sign is present, CT angiography is done. Then check for the pharyngoesophageal injury, laryngotracheal injuries, and vascular injuries. If any suspicion for pharyngoesophageal injuries, go for esophagogram or esophagoscopy. If both are combined, the sensitivity is 100%. If this test is negative, just give the patient another observation. If this is positive, then patient is mostly taken managed conservatively, and if the conservative management is failed, then the patient is taken for surgical repair. For laryngotracheal, absolutely. And so it's mostly like upper and lower. If panendoscopy is positive, again, mostly this patient can be taken up for operative room or conservatively managed, depending on the defect size. Like for the vascular injuries, first to diagnose the vascular injury from where it is leaking. So CT angiography, MR angiography, and color Doppler can be done. And if this is positive, then immediately take patient for the surgical repair.
Any questions to be done? So I think panendoscopic aim is when you use different modalities of endoscopy, which means I think so you have to go for fiber optic bronchoscopy, fiber optic bronchoscopy, laryngoscopy.
Laryngoscopy and tracheoscopy and all together is
So you explore both the windpipe and the food pipe. Okay, so the one way of doing bedside is you just do a fiber optic laryngoscopy that you can do bedside in the ED. For bronchoscopy, you can also do, but best is to take the patient to the pulmonary suite, and then obviously going for the endoscopy. So looking, I think, beyond and looking for both because this is a laryngotracheal injury, so you'll have to look for both larynx, trachea, and also the
Kiran, what is the kind of selective testing when the soft signs are absent in a patient? When we don't have soft signs also, like the selective testing in the
Because mostly like this soft signs, mostly these patients are asymptomatic. They don't come to the ED and don't say and show any signs. Like they are asymptomatic, so you may suspect any soft sign or any injuries. So we have to go for the diagnosis. Anything is there.
signs are absent, then like, is there any criteria in which you do for selective testing in the patient?
But it's not any very real there.
A patient with neck trauma who are like actively profusely bleeding from here, for example, One of the things you said is you don't ligate it, but just giving compression, can it cause cerebral anoxia? Because you are going to compress it, the carotid artery is like opposite side में injury होने के chances ज़्यादा है. So how can we proceed in these cases? Like actively entangled paralysis, actively bleeding. What can you do?
As I've shown in the slide also, initially it will start with hemostatic pressure, and 95% is stopped. If it's not something, then take the patient for the immediate surgical repair. Don't wait for the patient to bleed.
So then if they overwork it, like ये पड़ा रहता है patient most of the time. So those cases, is there anything?
Tamponade effect can be, Foley's catheter can be placed.
And to ask that, like, you said that transient mass catheter can be used in patients with penetrating neck injury. But in Italy, it was mentioned that patients who have been suspect of penetrating neck injury with very high risk of airway injury, whenever there is a distorted airway anatomy, we should not be using transient mass catheter. Like, is there any rule that it should be used or it should not be used?
Mostly, laryngeal mass therapy is a temporary measure. If there is any midline trauma, then we are not able to use LMA also. But there is a contraindication for this also.
Airway injury, I think we should not go. There's other injury here. There is a distortion of the neck. If there is a, obvious anatomical defect, then LMA is obviously not required. Then it's contraindicated. But then, if you are suspecting there are no hard signs, and then you can go for LMA. Midline changes नहीं है, fracture नहीं है. Examination पर depend करता है. You can have a very hard rule. So what does Netanyahu say? Do they talk about? Oh, in the airways.
That airway obstruction, pulmonary edema secondary to penetrating neck injury, we just checked. Written that there is post-obstructive pulmonary edema. Like the patient, because of the upper airway obstruction, the patient tries to forcefully inspire. Because of which there is a very high negative transpulmonary pressure, which leads to pulmonary edema.
Then airway obstruction leading to forceful inspiration, increasing the transpulmonary pressure, and then leading to. So it's a non-cardiogenic pulmonary edema. Post-obstructive.
Yes, sir. Like that.
How can you suspect or how can you confirm, say, upper airway injury, or say, esophageal injury?
There must be transludes. Any quick shadow can also be there. Like fluctuation can be like bleeds there, blood is there. Any quick shadow.
The laryngotracheal injury. Which point of view ultrasound and
The continuity of the tracheal rings, all disruption is there.
or suppose patient comes with say hoarseness of voice.
Vocal cord mobility.
These are example of a woman sitting on a rickshaw. LMA pass gay. She fell down. Came with hoarseness of voice and by the time she reached, within few minutes of arrival, she became unresponsive to that oxygen. So, इसमें first of all you said that you can check for the tracheal integrity by looking at the next scan. Next, what all can you see with point of view ultrasound?
All these things, upper airways, lungs, and lung appendices can also be there.
क्या देखो?
Sir, is any signs of
देखो तो
pneumonia?
इन्होंने बताया कि बच्चों को tracheal integrity वहाँ कहीं कोई जैसे breach, very obvious break है या नहीं?
Signs of pneumonia.
नेक्स्ट में क्या देखो?
Expanding hematoma.
Vocal cords देख सकते
No,
हैं.
vocal cord mobility.
Vocal cords की mobility देख सकते हैं. You can check for any currency. और क्या देख सकते हो?
Hematoma.
You
Lateral
can check
action.
for the paratracheal hematoma. Thyroid cancer. Then what you can check for? You can check
Like
for awake intubation. Many times you will not give paralytics to the patient. Awake intubation can be a difficult intubation because of high chances of associated cervical spine injury, especially if you don't have say your laryngoscope or high end equipment. थोड़ा सा आपको neck movement restrict करना है. So for dynamic intubation, yeah, neck movement ज़्यादा नहीं करो. Virtually a blind intubation. In real time, you are checking the movement through the glottis. Also, you are ruling out esophageal intubation. As also looking at the esophagus, you can also check for if there is a problem with the esophagus. Jeliya rupture. और उसमें हमने नहीं देखा, but mostly you can check for associated pneumonia. This will help you keep the intro for early intubation or not when the intubation can be really difficult. So you can easily do it, especially when for a patient relatively stable and not very high toxic. Take your time and do it. We'll have a scan and one.
Doing it, the airway ultrasound is very well. We're doing it all the time. ABC में airway ultrasound तो disaster में airway ultrasound air mucosal line देखते हैं ना, continuity of the air mucosal line. ठीक है. ठीक है, okay, thank you.
If you present too early, be ready for bombardment of questions. So it's important to be in time, not too early, not very late. 8 minutes का तो audience को time मत दो.
Next time इसको देखें जी के साथ साथ ब्रेन अभी trauma के चैनल पे हम करें. Blood culture डालो, AIMS blood culture.
मैंने अपने नेम चैनल
Hello, Rajvanshi, junior resident from the emergency medicine department, presenting you the video of sample collection for the blood culture in the suspected patients of sepsis. First thing, when to suspect sepsis in a patient. Hello everyone, I am Dr. Gaurav Rajvanshi, junior resident from the emergency medicine department, presenting you the video of sample collection for the blood culture in the suspected patients of sepsis. First thing, when to suspect sepsis in a patient. As and when patient triage as read according to vitals and as per the AIMS sepsis triage protocol, when patients presenting with fever with headache, or temperature more than 38 degrees Celsius. Hello everyone, I am Dr. Gaurav Rajvanshi, junior resident from the Emergency Medicine Department, presenting you the video of sample collection for the blood culture in the suspected patients of sepsis. First thing, when to suspect sepsis in a patient. As and when patient triage is read according to vitals and as per the AIM sepsis triage protocol, when patients presenting with fever with headache or temperature more than 38 degrees Celsius, cough with productive sputum, dysuria, or patient reported any skin redness or any skin soft tissue infection, or patient referred for any specific infection. And as per the Q-SOFA scoring, patients having altered mental sensorium, respiratory rate more than 22 breaths per minute, patients having systolic blood pressure less than 100 mm of mercury. हेलो, मेरा नाम डॉक्टर गौरव है। क्या अपना नाम कंफर्म करेंगे?
हाँ डॉक्टर साहब, मेरा नाम राहुल है।
अच्छा, आपको अभी क्या दिक्कत हो रही है?
मुझे तो अभी 9-10 दिन से बुखार है और अभी 2 दिन से ज़्यादा सांस लेने में परेशानी हो रही है और साथ साथ में कभी कभी छाती में दर्द भी होता है।
अच्छा, हाँ जी, फिजिकल एग्जामिनेशन करते समय भी ऐसा लग रहा था कि आपके फेफड़ों में इन्फेक्शन है और मैंने जो आपका एक्सरे कराया था उसमें भी निमोनिया जैसा पिक्चर लग रहा था। तो उसके लिए हमें अभी और जांच करनी पड़ेगी और उसमें से एक ब्लड कल्चर की जांच करनी पड़ेगी। उसके लिए हमें आपका ब्लड सैंपल लेना पड़ेगा।
ठीक है डॉक्टर साहब, आप ब्लड सैंपल ले लीजिए और जांच कर लीजिए।
थैंक यू। Hello everyone, now I am showing the equipment required for the collection of blood culture. These are the surgical gloves of size 7.5. This is cotton swab along with sterilium. This is tourniquet. And we have 3 kind of bottles. This is conventional blood culture bottle. These 2 are Bactec. This is for the fungal blood culture and this is for the bacterial blood culture. And we have syringes, 2 types of syringe, 20 ml.
वॉल्यूम क्यों नहीं आ रहा? अभी कनेक्टेड नहीं है। स्पीकर से कनेक्टेड नहीं है। स्पीकर है ना? नहीं, स्पीकर से कनेक्टेड नहीं है। These are important steps. There is some
Syringe and 10 cc syringe. Sanitize your hands thoroughly and using the swab to disinfect the septum of the bottle. Apply a tourniquet. Clean the site and palpate the vein. Apply clean examination glove. Again disinfect the skin and allow it to dry for the 30 seconds. Insert the needle into the prepared vein and collect the sample. Inoculate the blood culture bottle by holding the bottle upright. Always collect blood culture first if additional tests to be done. Discard the needle and syringes into sharps container and other as per the biomedical waste management protocol. Remove gloves and wash hands, label bottles and transport as quickly as possible.
We don't have backup bottles. I arranged from the medicine department, and they also don't have the anaerobic bottles. So that's how the aerobic only, and they have two kind of bottles, aerobic one and the fungal. Okay. And we have only one. Sir, they have your own lab, your point of care. Sir, microbiology, sir. Yes, sir. I actually have checked. I do the sample as 10 both. That the patient in the admitted site medicine, and they are positive that around for the 10 samples they have 2 to 3 positive, and we don't. But it's very unlikely that. So because maybe I am wrong, but it's not like that. With none of our residents know the correct way or. तो उनका सर 10 में 3 के आसपास 2 से 3 पॉजिटिव आ रहा था. हमारा 10 में 1 भी आ जाए तो बड़ी बात, मतलब 10 के 10 सर यहाँ से एक्चुअली जो मेडिसिन के यहाँ से आते हैं सारे बैक टेक से होते हैं.
का बस ये फायदा हो रहा है कि कुछ नए नए ऑर्गेनिज्म आ रहे हैं जो पहले नहीं थे. to sort of raise the awareness about blood cultures, which is the culture of blood culture is very important. We are hardly doing it in our department. We should be doing, for every sepsis, suspected sepsis patients coming to the red area on the counter, please think about blood culture and do that. The blood culture technique is nicely demonstrated in this video shown by Dr. Gaurav. There are minor mistakes which will be corrected in the next video. But one must do blood cultures. Blood culture yield rate is very low from the emergency. And the reason is the technique is not proper. And if you follow the good technique, we will get better yields. And that is how we will develop a ED-based antibiogram, which is what his thesis is. His thesis is ED-based antibiogram. There is no ED-based antibiogram from India. They have antibiograms based from ICU and from wards, but they are none from the emergency department from India. And this is the first emergency department antibiogram. And the Department of Microbiology is very excited about it as well. Two of their faculty are co-guides in this project. So we must make an attempt to sort of help this project. And if we have an ED-based antibiogram, then we can have our own antibiotic policy, and we can develop an antibiotic policy for the emergency department. So that is the attempt we are making in this project. So we need all of you to contribute and do blood cultures regularly in the best possible manner. So the bottles which we have usually available are not the Bactec bottles. Those are also good bottles. You can use them. Blood culture करना है चाहे कोई भी बोतल available. That is important. 10 ml इसने बोला नहीं. I think उसमें Gaurav we have to also insert that at least 10 ml of blood has to be taken. That you should very clearly say in your video. Okay? So 10 ml of blood देना है at least. One bottle is enough. We are not being given aerobic and anaerobic because most of our bacteria are aerobic bacteria, so we just have one bottle. So that is enough. You just have to put 10 ml there, and you should just send it to it properly, and the bottles are available on the counter in the fridge. They are kept in the fridge on the counter. You just have to ask the nursing staff to send it. Okay? So thank you.
Where you sterilize the bacteria bottle? How will you sterilize the ordinary bottles? Ordinary blood culture bottles? The cap of that. The bacteria, you just open the thing and then you just sterilize it by this spirit swab. How will you sterilize the ordinary bottles? उसमें तो छेद होता है ना, एक होल होता है, वो इस तरह से है। कैंसर होगा ना, देखा उसके होल के अंदर बैक्टीरिया होंगे। Back to the example, next example, people. See that coal is going to contain a lot of bacteria. Any idea? To ignite a spirit swab, tilt the bottle on top of that. Right? That is a way to sterilize that water. One is spirit swab, keep on a tabletop, one end, and tilt the top bottle on top of that. Sterilize it, whole area.
The swab. On the water and pour the liquid.
See that tape which is a liquid which is on top of that, and beneath all the bacteria is still there. We show the announcement on the video.
Yeah, 5 ml. 3 to 5 ml both in pediatric med. And they have, I think, Bactec bottles available there.
very good morning to all, respected faculty and my dear colleagues. I'm here to present a case of 36-year-old male who is a resident of Ghaziabad, UP, who is a four-wheeler driver who was brought to the trauma by the police to our JP Natak at 10 a.m. on 4th of May with elite history of road traffic crash where his four-wheeler collided with the divider at 4 a.m. on 4th of May. On injuries sustained, the patient complained of multiple abrasions over the back, left upper limb and lower limb. And he presented the symptoms of complaining of abdominal pain since the injury, and there was no treatment which was received pre-hospital to the arrival. On primary survey, his airway was patent and the C-spine was stabilized with a C-spine motion was restricted with a rigid cervical collar, which was of appropriate size. On breathing, he had a respiratory rate of 18 per minute, which was regular. He had a saturation of 98% on room air, and he was started on supplemental oxygen. There was no evidence of any visible injuries apart from on the chest. The bilateral air entry was equal, and bilateral chest movements were also normal. The chest compression test was negative, and there was no open sucking bone in the chest. There was trachea was midline, and there is no jugular venous distension, and the chest X-ray was ordered. In the circulation part, he had a pulse rate of 108 beats per minute, which was regular, normovolumic, with no radial or no radiofemoral delay. A blood pressure of 122 by 86 millimeters of mercury measured in the right arm in supine position, and a capillary refill time of less than 2 seconds. There were no obvious external hemorrhages that was seen after the patient was completely exposed. And on EFAST scan was positive with free fluid, which was noted in the hepatorenal pouch and the splenorenal pouch also. The patient was then started with 2 wide bore 16 gauge peripheral IV cannula, which were secured in the bilateral antecubital veins, and the relevant blood samples were drawn for blood gas analysis, cross-matching, and complete blood count. He was started on pre-warmed 1 liter of the ringer lactate, and the ECG monitors and cardiac monitors were attached. Pelvic compression test was performed, which was negative, and pelvic X-ray was ordered. On disability. So on circulation, the pulse rate was 108 beats per minute with regular, normovolumic with no radioradial or radiofemoral delay. A blood pressure of 122 by 86 millimeters of mercury measured in right arm in supine position. A capillary refill time of less than 2 seconds. There were no obvious external hemorrhage that was seen at this point. The EFAST scan was positive in the detecting the free fluid, which was noted in the hepatorenal pouch and splenorenal pouch. And pelvic compression test, which was done, was negative. And 2 wide bore 16 gauge peripheral IV cannulas were secured in the bilateral antecubital veins, and the blood samples were sent for cross-matching blood gas analysis and the complete blood count. The patient was also started on pre-warmed 1 liter of the ringer lactate, and the cardiac monitors were attached, and the pelvic X-ray is ordered.
Just one or two things. You ordered chest X-ray first.
So in the
You ordered pelvic X-ray later on.
So actually,
So you want to order X-ray separately.
So I would order both of them together actually.
So order later on. It's not just you can order chest X-ray first, ordering pelvic X-ray later on. Secondly, why did you know pelvic or pelvic chest first? You were the first one to examine the patient.
Yes, sir.
The first one.
Patient had arrived at our time.
Okay, you just say that.
Yes, sir.
Because I was in the patient, somebody else examined the patient first. Say clearly that.
Only one time the pelvic compression test was
Just say that
performed.
you are first one to examine the patient.
In the disability part, the GCS code was 15 by 15. The patient was E4, B5, M6. Pupils were bilaterally normal size and reactive to light. There was no focal neurological deficit noted, and the patient was moving all the 4 limbs equally. On exposure, the patient was completely undressed to find any external injuries. There were multiple abrasion marks in the left upper limb, lower limb, and the back. Hypothermia was prevented using the blankets, and urinary Foley's catheter was placed with 16 French catheter. There was no hematuria and clear urine was drained. For exposure of the back, the patient was examined by the log roll method. On inspection, there were no visible injuries or deformity of the spine. On palpation, there was no spinal tenderness or step-off deformity which was noted. On distal rectal examination, there was no visible rectal bleed. Anus sphincter tone was normal, and the content was the feculent matter, and there was no bony fragments which were felt. On secondary survey, the patient had no allergies. He was not on any medication and he had no known past illness. His last meal was around 4 to 5 hours before the trauma event. And events which led was the patient usually patient is actually goods transporter. He was carrying goods in the tempo, which was a four-wheeler, and what happened on that day was he had a long journey throughout the day. On the day of the road traffic crash, patient was feeling sleepy while driving at around 4 a.m. And the four-wheeler he was driving and he was restrained by the seat belt. Uh, he was in the front seat driving the four-wheeler and he was restrained. He accidentally fell asleep, after which the front of the four-wheeler had hit the divider at 4 a.m. on 4th of May, and it was near the Mathura, and he sustained a blunt abdominal trauma. According to the patient, what happened is after he had hit the divider, the patient's seat belt actually had broken, like detached from its this thing, and his steering wheel had gotten impacted. Like he sustained an injury from the steering wheel. After which the patient was brought by the police. And the speed of the vehicle at that time was around 80 kilometers per hour. On head-to-toe examination, there were no visible injuries, swelling, palpable fracture over scalp or forehead. On eye examination, the visual acuity was normal. Visual field examination could not be performed. On ocular motility examination, extraocular movements were full in all the quadrants. Pupils were normal in shape, size of around 1.5 mm and bilaterally equal. Both direct and consensual light reflex were normal bilaterally, and there was no RAPD which was noted. No periorbital injuries or edema or ecchymosis were noted, and no exophthalmos or inophthalmos. Orbital rim was palpated for any step of deformity, which was not there. Slit lamp could not be performed. On ocular examination, on ocular ultrasound, it was normal, and ONSD of the right eye was around 4.8 mm and left eye of 4.6 mm. Optic nerve sheath diameter of the right eye was 4.8 mm and left eye was 4.6 mm. On the palpation of the nose, there was no visible nasal injuries, bleed, septal hematoma, nasal deviation. There was no nasal bone fracture, which was felt on palpation, or no deformity also. On ears, there was examination of both right and left ear. There were no periauricular injuries, no mastoid ecchymosis, no pinna injuries, no bleed from the external auditory canal, and no hemotympanium, which was noted on the otoscopy. Palpation of the orbital rim, zygomatic bone, maxilla and the mandible were normal, and there was no tenderness or deformity which was noted. There were no malocclusion of teeth or tooth loss or fracture. On neck examination, there were no injuries noted on the front and nape of the